Good evening to one and all. IAP India digital team welcomes you all for today's webinar on spinal deformities, a closer look at the measurement and management strategies for idiopathic scoliosis. We wish all the physiotherapists a very happy World Physiotherapy Day on behalf of IAP India technical team. Now for today, we have IAP members of Tamil Nadu state. I, Dr. Neha Singh, would like to introduce Dr. S. Ramesh Kumar Sir as Joint Secretary, Dr. G. Arun Prasad Sir as Joint Secretary, Dr. T. Purnima Ma'am as General Secretary IAP Tamil Nadu, Dr. K. Selvamani Sir as EC Member, Dr. K. Y. Kiran Kumar Sir as State Treasurer. And I now hand over to Dr. Ramesh Sir for the continuation of the session. For today's webinar, we have resource person as Dr. Joshua Samuel Rajkumar Sir. And I also request all the physiotherapists to subscribe to our IAP India YouTube channel and also follow us on Twitter, Instagram, and Facebook. Thank you. Ramesh Sir, over to you.
Thank you, ma'am. Thank you very much. Good evening, one and all. On behalf of TNIAP, I would like to welcome you all for today's webinar. Today is the World Physiotherapy Day, and I would like to wish you all a very happy World Physiotherapy Day. Today, we have our resource person, Dr. Joshua Samuel Rajkumar, who is going to talk about the topic. And now and also I will thank all our TNIAP as well as the Central IAP who has given this platform for making this webinar in the YouTube and Facebook of IAP. Thank you very much. Dr. Kiran, please hand over.
Yes, sir. Myself, I am Dr. Kiran Kumar, and welcome to the webinar session on scoliosis by Dr. Joshua Samuel Rajkumar. And on behalf of Tamil Nadu IAP Physiotherapy, headed by Dr. Krishna Kumar sir, and the Central IAP, we welcome one and all. Dr. Joshua Samuel holds a graduation and post-graduation degree in physiotherapy and is also a certified aquatic therapist for musculoskeletal disorders from Aquatic Therapy Association of Chartered Physiotherapists, UK. He has produced over 100 scientific publications and conference presentations at state level, national level, and international level. And he has around 10 years of clinical experience in sports, performing arts, occupational health and safety, ergonomics, pediatric and adult neuromusculoskeletal rehabilitation. He was awarded the Student Doctor Grant in 2013 from the prestigious Oxford University, UK for the article on enriched environment, peer-reviewed by British Medical Journal and Centre for Evidence-Based Medicine, University of Oxford. And he has been trained and certified in the following areas of expertise: for research and publication, evidence-based medicine, application and its methods, scientific medical writing, aquatic therapy, both basic and advanced ergonomics, scoliosis specific training, and various types of specific training, scientific exercises approach for scoliosis like slide shift, Lion method, Iyengar yoga, Dobermed, and Carlton bone Vincent methods. And he is expertise in facial manipulation, level 1, 2, and 3, Steco method, aquatic therapy, and psychological approaches like cognitive behavior therapy, graded exposure, acceptance, and commitment therapy for chronic pain, and other functional and manual techniques for pediatric and adult neuromuscular rehabilitation. He has done internship at ISICO for scoliosis, EPM IES ergonomics, and Oras Hospital for spinal cord injury in Italy, and he's presented various research papers and have been peer reviewed and presented at national conferences in Chennai, Mangalore, Kolkata, international conferences in Oxford, Brussels, Copenhagen, Melbourne, Stockholm, Canada, and many more. Amsterdam, Mumbai, Ireland, Germany, Italy, Dublin, and Boston. And is the co-editor of the book on breakthroughs in muscle pain research and practice, and co-author of 2 chapters in the book of bridging research and good practice towards patient welfare. I need not waste the time, By
Yes.
reading, I think there are more to speak about Dr. Joshua's profile, and even me, I felt like more than 3-4 pages. His updations are, and we are fortunate enough to have Dr. Joshua as the resource person, and I hope that he will definitely find success and much more in his future. Thank you. I'm handing over session to Dr. Joshua.
Yes, thank you very much, and thank you very much to all the team for organizing this. And before we start up, warm wishes to all the physiotherapy fraternity here, because today is World Physiotherapy Day, and I'm happy to share this presentation with you all. So today's topic, what we are going to see is spinal deformities with a specific closer look, mostly into the idiopathic scoliosis. Okay. So in today's content, what we are mostly going to see is about the spinal deformities and scoliosis in specific. What are the assessment and measurement measures that we can take for scoliosis? What are the common treatment goals, treatment guidelines, and in specific about the rehabilitation, which is physiotherapy specific exercises for scoliosis. And last, a bit about what are the braces that can help along with the physiotherapy management, and a few case examples. With that, we wind up. So before we go ahead, okay, so spinal deformities, it is basically the deformities that can be presented as an unnatural curve in the spine. So commonly there are two deformities that can be commonly seen. One is the scoliosis, which is the increase in the side-to-side curvature of the spine. And the other one is the kyphosis or the Shearman's disease, which is the uh, front to back deformity, what is also commonly seen. So most of you have also seen other correlating other conditions like spondylolisthesis and ankylosing spondylitis that also cause a major deformity in the spine. But for today's talk, we are going to mostly see about scoliosis. Okay, so this is a pictorial representation of different deformities. What we are going to today more focus is on about the scoliosis. Now, looking at scoliosis, as I said before, it is the sideways shift of the lateral curvature of the spine, which causes change in the shape, position of spine, thorax, and the trunk. So scoliosis, the word scoliosis has come from scolios, which is from a Greek word which meaning crooked or curved. According to the Scoliosis Research Society, any curve which is measuring a curve angle of more than 10 degrees comes under the category of scoliosis. So this is very important slide in the presentation. Okay, so there is a shift towards an understanding of scoliosis from a two-dimensional to a three-dimensional perspective. So by two-dimensional to three-dimensional perspective, what we mean is the curvature, which we say that shift from the left to the right. Okay, so there has been a shift in understanding that the scoliosis deformities happens in only in two dimensions, whereas when you see in the picture of the right side, okay, so the deformities happen as a rotational deformity, which is the third dimension, which most of us fail to perceive so long. Okay, so for example, scoliosis mostly is determined by the side of the convexity. Okay, for example, for a left-sided scoliosis, when you say, okay, so there's a concomitant rotation behind, where the ribs are pushed behind posteriorly, and the thoracic cage is narrowed. Okay, and same on the concave side, the ribs are pushed laterally and anteriorly forward. So this is a cross-sectional view, as you can see, and the whole rotation happens. Okay, so the whole point of the curve shifting to the spinal curve shifting to the either left or the right side is because of the rotational movement which is happening there. Okay, so simply pushing only the convex side inside doesn't solve the scoliosis management purpose as such. Okay, so this is to put in short. Okay, so number one, so we look at the frontal plane alignments. Number two is we look at the sagittal plane alignments. Number three is where we look at the transverse plane alignments when we are about to treat an individual with scoliosis. So it is not only in one plane or two planes. So the main rotational deformity causing the rib hump and other spinal curvatures needs to be managed as well. So now coming to the prevalence. As we all know, today we're going to talk mostly about the idiopathic or the musculoskeletal scoliosis. And as we know that most of the scoliosis, what is prevalent is of the unknown variety, which is like idiopathic, which comes without an underlying pathology. Okay, so various studies have been published and reported the prevalence range, which ranges from as low as 0.93 to maximum of 12 percentage. So common commonly what is present in India and in most of the countries is about 2 to 3%, which is common, the prevalence of idiopathic scoliosis as such. Okay, so in general, most of us know that the scoliosis is prevalent more among girls as compared to boys. Okay, but this comes when the cob angle is rising as they grow up higher. Okay, as you can see, the cob angle between 10 to 20 degrees. So it is almost similar for girls to boys. It's around ratio of 1.3 is to 1. But as you can see, when the cob angle rises from more than 20 to 30 degrees or beyond 30 degrees, okay, the prevalence is more for the it's starting to getting more for the girls, is about 5.4 and 7 respectively. Okay, so now coming to the causes, as I already said in the previous slide, so the cause for the scoliosis is not fully understood because it is multifactorial. So having said that, the cause is not fully understood, but there are a lot of studies which had looked at what can be the other reasons of scoliosis being present in few individuals. Okay, some of those are estrogen receptors, melatonin synthesis disorders, presence of calmodulin and MMP3 and interleukin 6 biomarkers. Okay, so having said that, but these are not the specific causes for scoliosis. These are reported among people who already have scoliosis. Okay, so it is generally prevalent in people with scoliosis, but that doesn't say that the presence of any of these biomarkers or the chemicals so doesn't necessarily lead to the cause of scoliosis. Okay, so these are all case control studies or experimental studies which are still yet to be proven. Okay, now this is one important slide. What we need to understand is the natural history of scoliosis. Okay, so what determines the scoliosis getting more and more worse or the curve getting more and more severe? Okay, so first important thing is the starting stage of the scoliosis, which is the childhood or the adolescence. Okay, so the scoliosis, if it starts very early as the childhood, okay, then obviously the natural history of the scoliosis is going to be more and more severe compared to the adolescence, which happens in the later periods. Okay, so scoliosis normally presents, especially the idiopathic scoliosis, presents to us in either in any of three of these growth spurts. Okay, so growth spurts happens especially in this three major spurt phases in life. So first is between the first 1 to 2 years of life. Second growth spurt happens between the 5 to 8 years of life, and the third growth spurt is during the puberty growth. Okay, so for example, if a person presents to you with the scoliosis as early as 2 years or less than 8 years, okay, normally the chances of him or her getting the curve to be worsening is on the higher side compared to somebody coming to you or presenting with the scoliosis at a very later age, like about 17 years or 18 years. Okay, why I say 17 years or 18 years is by the time the skeletal maturity will already be done. Okay, so the point here we will also be discussing later in the slides is the earlier the detection is or the earlier we come across individuals with scoliosis, it's better to manage them. Okay, so the important thing is the last point. What you need to understand is the will scoliosis progress? So that is about the natural history, right? So will scoliosis progress after I finish the skeletal maturity? Yes. So that depends on how well you manage the curve and keep it less than 30 degrees. So what has been reported is if the curve remains stable, so the curve will more likely to remain stable. Okay, if till the skeletal maturity is done, for example, like 18 years or 19 years for girls or 20 or 21 years for boys. So if the curve remains less than 30 degrees, then more or less likely the curve will remain stable and it won't progress beyond the adulthood or in their adult life. Okay, but if the curve is more than 50 degrees, okay, then obviously there is other chances of progression into their adulthood. Okay, so the main challenge is with us. Okay, if somebody coming to you with a mild scoliosis or something, it's very important for us to control the curve or limit the curve from crossing beyond the 30-degree curve angle limit. Okay, now coming to different types of scoliosis, already we have discussed before. Okay, so mostly the idiopathic scoliosis what we are getting discussed today, but there are other types of scoliosis what you see in spina bifida or after a spinal cord injury or any other muscular dystrophy or any other neurological conditions. Also there are other scoliosis, but those requires different line of management which is not covered in this presentation. Here we are mostly talking about idiopathic and purely musculoskeletal. Okay, so coming back to the classification of scoliosis, again the scoliosis can be classified into three different categories, as you can see now. So it is based on chronological age wise or angular based on the curve angle or based on the area where it is located. Okay, so chronologically, so if it happens less than 2 years of life, then it is called as infantile scoliosis. Between 3 to 9 years, it is juvenile scoliosis. Between 10 to 17 years, it is adolescent. and more than 18 years, it is termed as adult scoliosis. Coming to the angular part, so if the cob angle is from 10 degrees to 20 degrees, then it is a low-grade scoliosis. If it is between 21 to 35, then it's moderate scoliosis. Between 36 to 40, it is termed as moderate to severe scoliosis. Beyond 40 degree and less than 50 degree, it is termed as severe scoliosis. Beyond 50 and 56 are like severe, very severe scoliosis, which can be managed only through surgical management. Okay, so coming to the based on the location, it's based on the anatomical location of it. So whether it be cervical or cervicothoracic or thoracolumbar or lumbar, as you can see here. Okay, so most children and adolescents, they present with either a single curve, which is like at a single region, like a cervical or lumbar scoliosis, or they might have a compensatory scoliosis, either for example, the right thoracic or left lumbar, or the right lumbar or the left thoracic compensatory. Cervical scoliosis are relatively less in number. Okay, now coming to the measurement strategies, these are very important. Okay, so this is very important to identify. Okay. As we said before, the natural history of scoliosis, the earlier we identify, it is better. We can try to stop the curve from progressing beyond a particular range so that it remains stable throughout their adulthood. Okay, so the simplest screening tool what we use to measure the scoliosis is the Adams test. Okay, so we ask the patient to stand straight, and the examiner is behind the patient. The knees are straight and feet are 1 foot width apart, and ask them to bend forward as if they are trying to read something from the floor. Okay, so usually the Adams test positive is something where there is a visible hump is seen on one side. Okay, which you will not see in a functional scoliosis. A structural scoliosis clearly has a visible hump, as you can see in the picture. Okay, which determines that an individual has a scoliosis. Okay, the hump side represents the side of the scoliosis. So the picture depicts the right-sided scoliosis. Okay, so the second most key measure what we can do to measure scoliosis is, now we know that hump is there, but we need to understand what is the angle of the trunk rotation. Okay, so the commonly used device to measure that is the scoliometer. Okay, which measures the angle trunk rotation, or we call as the angle trunk inclination, ATA or ATR. So at the bottom slide, at the bottom of the slide, you can see the sensitivity and specificity of it. Obviously, it is very much rater dependent, and also it varies with the change in minor positions. Okay, but this is one of the easiest measures, so that can be easily correlated to the cob angle. But it doesn't directly correlate to cob angle, but it can be related to the cob angle. So what I mean to say is, if ATR, if the angle trunk rotation is higher, obviously the cob angle will also be more. So this can be directly proportional. Okay, so instead of taking repeated radiological measurements, this is an indirect way of measuring it. Okay, and so nowadays there are lots of other applications are available in the mobile, which can be downloaded by a Play Store, like the inclinometer app or the clinometer app or the on protractor apps, with which you can easily measure this scoliometer as well. Okay, now the next commonest measurement what we measure is the plumb line measurement. Okay, which is like what the common masons use. Okay, it is like a weighted device tied from a thread. Okay, we hold it at the level of the base of the skull. Okay, and let it hang down. Okay, so here we measure two profiles. One is the frontal and the sagittal profile. Okay, so how in the first picture you can see that how much the head is deviated from the pelvis. Okay, that you can easily measure here. Okay, regularly. So if more the head is deviated from the pelvis, the more is the angulation, and the more the shifting is tend to happen, and you need to intervene more. Okay, and the sagittal profile is the measurement which we can take at different levels of the cervical, thoracic, lumbar, and the sacrum. Okay, which determines how much the compensatory lordosis or the kyphosis is as well for a patient with scoliosis. Now coming to the important radiological measurement. Okay, so before I go to the Cobb's angle, there is other thing what we need to understand is the Reiser sign. I think most of you know about it. Okay, so Reiser sign is an indirect measure of the skeletal maturity. So how much skeletal maturity has happened for a particular individual. That's why most of the time when we ask an X-ray for a patient with scoliosis, we ask them a full X-ray so that it covers the iliac crest till the iliac crest. Okay, so for example, so when we say the Reiser sign, it ranges from 0 to 5. Okay, 0 is where the skeletal growth has not yet started, and you can see a small thin white line layer, right? So as it goes, as the patient's age grows or the patient's skeletal maturity is growing simultaneously, the curves growth is also more likely to happen. Okay, so by 5, okay, the skeletal growth is fully completed. Okay, so for example, when a patient coming to you at the age of, or at a very smaller age with a Reser sign of only in 2, and presenting to you with a very severe scoliosis of maybe like say 45 degree or 50 degree, so he or she has lot more years for skeletal maturity to go. Okay, so we need to be more intensive in our treatment so that the curve's progression is stopped. Okay, and on the other side, when you see, for example, a patient coming to you with a Reser sign of 4 and has a degree of 20 degrees or something less, okay, so it is, he or she is on a safer zone. Okay, because only few more years of skeletal maturity is left, and the scoliosis has not increased to that particular level, which is much more severe. Okay, so it's easy for us to manage on those signs as well. Now coming to the corpse angle, okay, it is easily measured. Nowadays there are also a lot of apps are available in the PC as well as the mobile with which you can measure it. Okay, so you can upload a photo, and so we draw a line from we draw a straight line from the top margin of the topmost displaced vertebra and the lower margin of the lowermost displaced vertebra. If the line joining between both is the corpse angle. If the lines are not joining, then draw a perpendicular from each. So where the lines meet, that is the other way of measuring the corb angle as well. Okay, some do measure on the convex side, but that doesn't nearly matter because both should have equivalent values. And again, corpse angle also, there is a lot of reliability differences as well. Okay, which they say that as low as 5 degree of measurement errors can still able to happen between rater to rater. Okay, so the next most important measure what we can also measure is the surface assessment, which is nothing but the measure to measure the aesthetics. Okay, so aesthetics is nothing but how good the spine or the back is looking from behind. This is very important. We'll be discussing about this in the further coming slides. Okay, so trace, as we can say, is a trunk aesthetic clinical evaluation. Okay, it is a tool with which we can measure these 4 domains. One is the shoulder asymmetry, second is the hemithorax asymmetry, third is the scapular asymmetry, and fourth is the waist asymmetry. As you can see here, these are like pre-coded photos. Okay, they score it before itself so that it gives us a guideline. Okay, so we take a this is not usually measured live. Okay, we ask the patient to stand, and when we take the usual clinical photos, we take it, and post the clinical photos, we compare and measure it. Okay, so for example, I say one example, when we measure the shoulder asymmetry. Okay, so compared to this picture, how is the picture of our how is the picture of our client? Okay, it is 1, 2, or 3. So based on that, we score it. Same way for the hemithorax, same way for the scapular asymmetry, and same way for the waist asymmetry. So there are four different domains which can be measured, and we add it up. Okay, so as we can see, it can be easily said. Okay, higher the score, the more is the asymmetries. Okay, the lesser the score, the better it is. It is one way, an objective clinical measurement to see whether your aesthetics is improving or not. Okay, the other important measure is the quality of life measure. Okay, which we can measure by the SRS 22. Okay, this is Scoliosis Research Society 22 questions. Okay, this is a revised version. This is also available online on the following link. Okay, with which you can see it's orthotoolkit.com/SRS22. Okay, this measures on 5 different domains. Okay, what is the function and activity of the individual, pain, self-image, mental health, and satisfaction with treatment. Okay, so again, same. So this also is a measure to measure the quality of life of individuals with scoliosis. So other biomechanical measurements, what we can also measure is the range of motion of the trunk in flexion, side flexion, rotations, because as I said, it is a 3-dimensional deformity, and more likely most of the 3-dimensional movements tend to get restricted with time. Okay, so it's important to have a measure or follow-up until the skeletal maturity is done so that we maintain the flexibility throughout their adulthood. Okay, the other important measure is the chest expansion, because as we know, the scoliosis affects the rib rotation, which is causing the hump. So further the rib humps get more and more and it gets narrowed, there is a likely chance that the breathing and the chest expansion are likely to get affected. Okay, so regular chest expansion, the common measurements taken at the axilla nipple level and the xiphoid level, the differences between inspiration and expiration is a good amount of chest expansion measure as well, which you already know. Okay. Now coming to the treatment guidelines. Okay. So according to the evidence-based treatment guidelines, so most scoliosis practitioners, they follow what is being given by the Scoliosis Orthopedic and Rehabilitation Treatment. So they have their own website with which there's a lot of guidelines, what a team of professionals around the world, they do research and clinical practice related to scoliosis. They do an update. Okay, so this update, what I'm going to present is till 2016, what they have done and what they recommend. Okay, so I'm basically focusing more here on the conservative management. Okay, so by conservative management, we mean exercises and bracing. So the PSSC stands for physiotherapeutic scoliosis specific exercises, which we'll be seeing later on in the slides. Okay, and the bracing. Okay, so why we do this? Okay, basically for 4 reasons. Okay, one is to stop the curve progression at puberty. As we already discussed before, the important thing is, the major thing, we need to stop the curve from progressing beyond 30 degree or around that degrees till they attain the skeletal maturity. That is one of the major reasons why conservative management is recommended, because if it goes beyond the 50 degree or 55 degree mark, so surgery is the only option. Okay, then the second option is to prevent or treat respiratory dysfunction, to prevent or treat spinal pain, associated spinal pain syndromes, and to basically to improve the spinal aesthetics, how well they look, the self-image, body image. These are all very closely related to scoliosis, especially because it is a body affecting condition physically. Okay, and the secondary goals are to maintain their psychological well-being, quality of life, disability, and its associated disability, and stopping it from progressing it into the adulthood. Okay, so first, so there are a lot of other lot of studies has been done, especially a long-term RCT follow-up RCT was done, wherein they found that PSSC can help in reducing the cob angle as well. Okay, and also the bracing also standalone can be a good effective treatment in progressing patients who are more likely to go for surgeries. Okay, so important thing, the first and main important goal of any scoliosis management, especially considered, is stop the curve progression. Okay, second is to prevent the associated respiratory dysfunction, as I already said, because it is affecting the, especially the thoracic scoliosis and affecting the chest. Okay, there's a lot of compensatory respiratory mechanisms that can happen. Okay, so a lot of focus on this also needs to be done. That is one of the secondary goals, to maintain the respiratory functions. Okay, next is to prevent the associated pain syndromes. So normally when the muscles and bones and the surrounding tissues goes into tightness or weakness, a lot of different changes. Okay, obviously there is associated painful conditions that can happen, so those needs to be addressed. And the last is, as I already said, to improve the aesthetics, because aesthetics is one of the major component. Okay, that most of the individuals with scoliosis, especially because as this falls in the adolescent or the teenage category, most of the body image or the self image what they talk about is getting affected. Okay, so one main thing in the conservative management, what we look at is improving the aesthetics by the use, there are lots of other scales, but the trace scale what we discussed before is one of the easiest measure to measure. Okay, and also objectively, observation wise, we also see that the aesthetics is getting better at every follow-up assessment what we do. Okay, so because the visual correction of scoliosis is also equally important, and not all severe scoliosis present with a big for example, even a 50 for example, the girl whom you can see in the picture on the left side, she has a 55 degree scoliosis, but the main thing is in the um, while in the aesthetic measurement it can be very less as well. It's all about how aesthetically the exercises are going to help them in maintaining the spine in a corrected posture. Okay, so now coming to the treatment goals. Okay, so there are basically 3 different categories in it. Okay, one is the absolute goal, which is nothing but the minimum expected goal what we require when we give an intervention. Primary goals is the best possible what can be achieved. Okay, secondary goals happen when the primary goals are not met. Okay, now coming to the absolute goals. So why we do the conservative management of scoliosis? First and foremost is to avoid the surgeries. Okay, so that we maintain the patient at well within limits of the angulations, so the corpse angle. Okay, second is improve aesthetics and thereby to improve their quality of life as well, so that they perform other functional activities and functions and their aerial activities as well. Okay, now coming to the primary aim. Okay, so for a degree which is as lower degree, okay, the primary aim for us is to maintain it below the 20 degrees. For somebody presenting with a moderate scoliosis, the primary aim for us is to make the degrees remain below 30 degree till they attain the skeletal maturity. For somebody presenting you with a severe scoliosis, our aim should be maintaining it less than 45 degrees. Okay, so if these two doesn't happen, what our secondary aim should be is, when somebody is presenting with a low degree scoliosis, secondary aim, if 20 degree doesn't happen, okay, so we make sure that it doesn't cross the 45 degree. When somebody is presenting with a moderate degree scoliosis, we make sure that it remains below 45 degree. If somebody is coming with a severe degree of scoliosis and they remain below 45 degrees, it is okay. But if they don't remain below 45 degrees, then the other option, then the secondary aim should be to postpone surgery or any other options. Okay, but if it goes beyond 55 or 60 degrees, okay, then surgery is the only option. Okay, now this is a simpler example, so don't get confused by the table. Okay, so you can concentrate on the green marking as an example what I've taken. So I already told the razor sign represents the skeletal maturity. Okay, 0 is the skeletal maturity, so the child might be very lesser age, like around 3 years or 4 years. So as the child grows up, the skeletal maturity grows up. Razor 4 might be approximately, maybe we can say 15 years or 16-year-old child. Okay, so when somebody coming to you, okay, so what can be the likely treatment options? So OBS stands for observation. Whatever ends with B, so those are bracing. Okay, so don't much bother about what is it. So S stands for soft bracing, R stands for rigid bracing. Okay, so these are other options. So what we are more bothered about is the PT exercise, which is a PSSE. Okay, so SU stands for surgery. Okay, so when somebody comes to you with lower grade scoliosis with a razor sign of 3, okay, as I said, low grade scoliosis falls less than 20 degrees. Okay, so they call it as observation or monitoring on a regular basis. That is enough. But most of the individuals present to us with a moderate degree scoliosis, which is beyond the 30 degree range. Okay, so when somebody present you with razor 2 with a moderate degree of scoliosis, what can help them is exercises plus bracing, or exercises alone sometimes. Okay, so it's important for us to make sure we make a good clinical decisioning based on the guidelines. Okay, so similarly, they have given it for juvenile, infantile, adult, elderly. Okay, this paper I can later share it across to the IAP team so that they can share it across to the team as well. Okay, so coming to the guide, what are the studies which have been concised and presented upon. Okay, as you can see, okay, so specific exercises to prevent scoliosis progression during growth, and specific exercises during the brace treatment as well as post-surgical therapy. Okay, so that also provides a good considerable amount of evidence as per the consensus statement. Okay, now coming to the rehabilitation. Okay, so what is PSSE? Okay, so physiotherapeutic scoliosis specific exercises involves, there are different schools of thought which we'll be discussing. Okay, but majorly one of the major things what we talk about is the self-correction. Okay, self-correction is nothing but the patient does the corrective movements by himself or herself. Okay, and the major second principle what is required for the scoliosis exercises are elongation. Okay, as you know, for example, when they present with a curvature, the easiest way where one can do the elongation of a spine or something which is bent or rotated is to pull apart. Okay, to elongate. Okay, so that's why a lot of hanging exercises and that's a lot of stretching exercises that can help in the spinal curvatures to a greater extent. And the third point is to improve the chest wall expansion. So as I said before, as the curve gets progressed, especially if it is on a thoracic curvature, okay, it can compromise the lung function as well. So that's very important, so that the breathing exercises component is also part of the PSSE program. Okay, and the whole point of maintaining this corrected posture in the everyday activities. For example, they maintain this during their school hours, they maintain it during their homeworks, activities, sports, etc. Okay, so there are different schools of thoughts. Okay, as far as what has been reported, there are basically 7 schools or programs which are reported for PSSE. Okay, so so why this? So what is this components of this PSSE? Okay, so first is about education. Okay, so we explain the patient and the parent about all these things what we discussed. What is scoliosis, how it happens, how in a way that it can hamper, or how it can, for example, how can it be reduced, what are the possible treatment options, and those and all are given for the patient as well as the parent, so that they know that it's a long-term follow-up they need to make. It is not a one-off visit or something. So they follow up with us at every regular intervals till the skeletal maturity is done, and every 1 year or 2 years once they had finished the skeletal growth. Okay, so then we explain about the exercises, then observation monitoring as we said before, and the important thing is providing psychological support, because there's a lot of impact it has on individual with scoliosis, their what to say, their kind of the way they look at their body, the way they psychologically more confident enough or not in doing certain things because of this. So there's a lot of psychological support that is required. Okay, that is also part of the conservative management as well, and as well as the bracing. Okay, so PSSC doesn't stand alone; it stands along with the other multidisciplinary team as well. Okay, so basically, so I'll go to the PSSC, then I'll come back here. Okay, so basically there are different, as I said, there are 7 schools of thought. Okay, so most of this schools or the scoliosis programs have started from the European methods. Okay, so each country or almost most of the major countries had their own methods of treating scoliosis, with which the method started expanding to other regions. Okay, so the first most method what has been formed is a Schrock method, which is from the German method, and from there it is split apart, and as for what is being followed in Spain is the Barcelona Physiotherapy School scoliosis exercises. Okay, both has more or less the similar principles, where they divide the scoliosis into different categories like 3C, 4C, N3 and 4 thoracolumbar scoliosis, and there are specific exercises for all this. As I said before, the 3D correction has started from there. Okay, where they correct the spine into different blocks in all these 3 major corrective components. Okay, the other commonest method what has been reported is the CEAS approach. It's from the Italian method, ISICO. Okay, so they focus a lot on self-correction. Okay, in Schrock method they focus on a lot of passive corrective equipments like the rice bags, wedges, etc. So here in CEAS method they focus a lot on self-correction, which is more active. Okay, so they actively do the corrections or the derotations as opposed to what has been already happened for them, the rotatory deformities, and they try to maintain it in their everyday activities. So they have a series of exercises and they do follow up, etc. a lot, and that's how they go about it. So there's a lot of active correction that gets involved in it with their specific principles as well. The other method what has been followed is the Poland method, which is the Doberman method. In Doberman method, there are basically there are like key exercises, but one of the important thing is the Doberman is they focus a lot on the kyphotization of the spine. Okay, so when we always see patients with scoliosis, it is more towards like the hump. Okay, we forget to focus on the flattened area, which is on the concave side. Okay, so the same effect or the same concentration what we focus on reducing the hump or the curvature, so that with the same focus we need to focus on bringing the concave side also little bit more expansion. As you can see in the black and white picture, you can see here. Okay, there's a lot of effective focus exercises on bringing the concave side also enlarged here, so that the sagittal profile is symmetrical on both the sides. There are different exercise methods also in this Doberman method. Then there comes the Lyon method, which is popular in France and is developed in France. Okay, so this happens along with the Lyon brace. So when I say Lyon brace, that's a brace what they commonly use in France. So similarly, each schools have their own specific braces also. So they always do exercises along with the braces as a conservative management. Okay, but in Lyon method, basically they focus on this particular cycle what you see here. So they consider wedging of the vertebra as the primary cause of the scoliosis, and the spinal deformity or spinal curvature happens as a cycle. So stopping the triggering event helps in correcting the curve progressions. Okay, so they follow this 12 points, key points of principles: awareness of their postural defects, kyphotization again as in Doberman, passive mobilization of vertebral joints, opening the iliolumbar angles, active mobilizations, lumbar sagittal and frontal correction, thoracic sagittal and frontal correction, and other specific exercises. Okay, so next method is a method which has originated from UK. It's a side shift method. As I said before, this corrects mostly in the only 2-dimensional plane or even 1-dimensional, as we can say. Okay, so when it is shifted, okay, so they they focus on shifting to the opposite side as well as over correcting it. This is one of the other principles what they follow in the side shift method. Okay, so where they focus on shifting along with the over correction of the spine. For example, somebody with a right scoliosis, okay, for example, right scoliosis, they focus on not only correcting it to the neutral, but also in over correcting it. Okay, so in due period of time, they tend to get better. Okay, but this is, as I say, these are just principles with each method as evolved. Okay, and it is up to the practitioners what we put in use for our according to the what we make the good clinical decisions on. Okay, so these are about the specific methods. Okay, and have a note in mind, each method has its own pros and cons. Okay, so we use the best possible corrections. Okay, and we make sure that that gets transferred into their everyday activities and their functional movements. That is more important. Okay, because especially they are in their adolescent and teenagers, so they need to live a more active life as well. Okay, so the other things what goes along with the exercises are the braces. As I said before, the commonly used one is the Boston brace. There are different varieties in it. The front open and back open, the different varieties are there. So in India, most of them they're well versed in using the Boston brace only. Okay, so the other braces what is available are the Rigocheno brace, okay, which they mostly follow in the short method, and the Jensingen brace. Francesco brace. This is one of the braces what they do it in they say called the CIS group. Okay, so the one of the other braces is the soft bracing. It is like the spinal cord brace, where there is no, it's not a rigid bracing. It's considered as a soft bracing where there are different belts going in different angles for correction. And obviously, as you can see, so these are not effective for moderate or even severe type of scoliosis. Less than 30 degrees scoliosis, these can help in correcting the curves. Okay, now coming to the case examples. Okay, so as I said before, a lot of exercises for should be focused on spinal elongation. Okay, maintaining the correct making sure they do the three-dimensional correction. Okay, three-dimensional correction, I mean in the frontal plane, in the horizontal plane, and as well as in the sagittal plane. Okay, so we maintain it and we give them different modes of exercises in different positions like sitting, standing, walking, hanging. So, and using different exercise items so that they get more active, more strength, and more flexibility. So, if with the corrected posture. So, when all these things is there, naturally they tend to get a better. At least, if not the curve getting progress, the main aim is to stop the curve from progressing. Okay. So the exercises are suitable as very less age as possible. Okay. Only thing is the child or the individual has to cooperate or understand the exercise what we say, because as I said, a lot of exercises depends on their self correction. Okay. They need to understand how exercise needs to be done and what are the planes they need to correct it, etc. Okay. So that, as I said before, we do not have exactly a scoliometer or something to measure the angles. There are a lot of other apps which are easily available, with which we can also regularly measure and monitor. Okay. Now moving into the COVID situation, a lot of distant training in tele-rehabilitation can also be done, where parents take majority of the role in regular assessments and follow-up for the children as well. Okay. So this is another example. Okay, so this majorly I put to make sure that the aesthetics are getting very important as well. Okay, so when you make sure that the aesthetics are getting very much better, the encouragement and the motivation of the individuals also get better, so that the exercises are being followed well and carried on forward. Okay, this is one of the case examples what has been followed for the last 1 year with us. Okay, so as you can see, when it falls beyond 44, around 40 degrees plus, okay, it always comes on the severe side. Okay, so making sure that we get that back to under 35 degrees or 30 degrees is one of the very important things. Okay, so the next goal for us would be to make it come less than 30 degrees and make sure we sustain that. So the child is around 11 years or 12 years now. Okay, so we make sure that another 6 years the curve doesn't go beyond the 30 degree, or if it goes beyond the 30 degree, we make sure that it doesn't go beyond the secondary aim, which is not beyond the 40 degree or 45 degree. Okay, so a regular monitoring. Okay, so when we do like every month. Okay, so the x-rays are done every 6 months, because mostly the too much of x-ray exposure is also not likely recommended. Okay, so if the patient is using brace and if there is a regular brace trial or brace off is there, then 6 months is recommended. And if in special cases, 3 months X-rays can also be done. But in general, X-ray every per year is the highly recommended one. Okay, till they attain the skeletal maturity. So in conclusion, so idiopathic scoliosis has a lot of quality evidence-based conservative treatment options, combination of exercises and bracing. So approach a patient with scoliosis three-dimensionally, not only putting them on the convex surface and convex and opening out the concave, and it not necessarily to be done in the lying position. Okay, we can start in a very functional position as such as sitting, standing in a more functional way, so that because that is what they are going to maintain throughout their everyday activities. So that needs to be kept in mind. Then the important thing, what we need to consider is the aesthetics. How is the look of the back or the frontal side? How is their activities of daily living, breathing function, pain, and quality of life? Okay. So awareness among people and the professionals are also slowly increasing. So better awareness leads to better identification or early screening of the scoliosis. If we identify it early, it's easier for us to better manage, because once a skeletal maturity is done, it is very difficult for us to get the curve down. Okay. So what we have in time in our hand is still a girl or boy is still 18 to 20 years till they have skeletal maturity is done. The earlier we diagnose or we screen them or we find them, we arrest the curve and work on reducing it. Okay. So manage conservatively with exercises and bracing for mild to moderate scoliosis. That is the rule what the evidence says, and keep monitoring and follow up till the skeletal maturity is there. Okay. So thank you very much to the team for giving me the opportunity. Okay. And before we go into the questions, okay. So I think most of you know Usain Bolt, right? So he also has a minimal degree of scoliosis. Okay. So scoliosis doesn't stop anybody from performing to the maximum of the potential. It is up to how strong they are and how strong they are in the minds and how we motivate them and do them. So that's all matters. So same like Usain Bolt, there are a lot of other key professionals or key celebrities, etc. A lot of scoliosis were done greater achievements. Okay. Scoliosis is something where we can, if we intervene early, it is easy for us to manage at an earlier period. So the tagline is skeletal maturity, the 30-degree curve angle. So we make sure that we maintain less than that, then everything falls better. If it goes beyond the 30-degree mark, after that, then there's a chance of progression in childhood. So maximum up to 40-45 degree, we work towards applying the exercises and bracing to make sure that they don't go beyond that. Okay. So any questions? We are open for questions now.
Okay. Thank you very much, Dr. Joshua Samuel. We have just got a couple of questions here.
Okay.
From a question from Smita Rani. She had asked, what is your suggestion for treating scoliosis in spinal muscular atrophy?
Yes. So that's what, sir. So this, the methods or the discussion what we had today is mostly towards, as I said, idiopathic scoliosis or the musculoskeletal scoliosis. As you know, the spinal atrophy, the scoliosis, what happens is due to a lot of, there is a muscular involvement is there, and progressively the muscles get atrophied as well. So for spinal muscular atrophy, the maximum what can be done is whatever the limited what is a kind of the functions or the range what they have, we try to maintain that and stop them from progressing. Okay, with proper positioning, if possible, some braces can be advised, etc. But those is a but the scoliosis which happens due to spinal muscular atrophy are totally a different category. Okay, those doesn't fall under this schools of thought. These schools of thought mostly work towards idiopathic scoliosis and purely musculoskeletal scoliosis.
Okay, sir. Thank you. And another question from Akifa Anjum. Sir, can you tell me what the apps you said to measure the scoliosis? So I think she's asking about the name of the apps which will measure the scoliosis.
Yes, it is called On Protractor. It's available on Play Store. On Protractor, PROTRACTOR, or there is another one called Clinometer, CLINOMETER, Clinometer.
Okay, sir. Thank you.
Yeah, that can be done. And for the X-ray also, for measuring the curve angle also, there are apps available. It's again the same. Protractor apps can be used. Okay. So there are a lot of so wherein we can upload a picture of the X-ray. So and we measure, and that can be two lines that can be marked. So the different the points where they converge, they give it an angle. So but it's all about how you take the picture from the X-ray. Okay, so put it on an X-ray viewer, that is better, so that we get an angle straight. Okay, and always there is, as I said, there's always an error of around 5 degrees when you measure the curve angle.
So related to this also, sir, just I'm having a question like this apps, how reliable is this apps? Like we are having like scoliometer and other
Yes,
measurement gadgets are there,
yes.
but this apps, how reliable, how can we rely on this?
Yes, sir.
Can
So
you
there are
just
always a
have a word on?
reliability issues there. So it's we can take an approximate value, okay, because error between 3 degree to 5 degree is what they say. Okay, sir. So for example, if we get an angle of maybe say 32 degrees or something, we can say like 32 degree plus or minus 3 degrees. Okay. So
Okay.
it's always because now in this COVID situation, most of the time over the tele rehab or something we do with the parents doing it, then obviously there's a lot of parental, I mean like training errors from an non-healthcare professional related measurements are being taken. So that error needs to be tackled as well. So, but with due training and due uh, amount of practice, they can able to better at it as well.
Okay. Okay, thank you, sir.
Yes,
And the
sure.
next question from Ashraf Yasin: which age we need to suspect to have a monitoring?
Yes, sir. Obviously 8 years. So one of the other growth spurts, the second growth spurt we talked about, no, 8 to 10 years, approximately 8 to 10 years. Okay. So most of the patient they notice that particular phase. So out of the three growth spurts, okay, the second growth spurt is most likely, and especially after the puberty. Okay. So after 13 years also. Okay. But the first identification, and so that's why we are working towards organizing a lot of awareness camp in schools. Okay, because once we train the teacher, and obviously now with all this COVID, when the schools doesn't happen, etc. But before, when all the regular schools used to happen, we planned of trying it like having regular school awareness programs where we train the teachers to find among the students very early, because most of them they confine this, because nowadays with all this uh, independency, etc., and everything. So where exposing their body even to their own parents or somebody is getting limited, it's very difficult to identify unless. So the commonest screening tool what I discussed is the Adams test. So if they do an Adams test and they can easily identify there's a visible hump, then that's done. So from there they can refer it to the appropriate professional. So from there they can take it forward and for the proper treatment or management.
Okay, 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 thank you, sir. And the next question from Shankar Subramaniam: exercise prescription of kyphoscoliosis. So
Yes, sir.
what?
That's what we have discussed. So there's a lot of principles, but the exercise principles are similar to as much as any other exercise what we give for a low back pain, etc. But along with the exercises, we need to make sure that they self-correct at three different planes. For example, somebody with a right scoliosis, so shifting, rotation, and elongation. So we correct at three different planes by their self, and we do our regular other exercise principles. Okay, but having said that, those are like simpler exercises. But if somebody is having a double curve, okay, then we need to make sure how is the other curve. For example, when you do the shifting on one of the curves, the other curves tends to get worse. Okay, it's all decision making. That's why a lot of additional courses or other books or all the papers available on different methods on whatever schools I have discussed. So there are a lot of papers available on those schools, and books are also available. So it's also freely available, I think, for India. So you can download and get it, or maybe he can message me or mail me later on so that I can happy to
Okay,
share with him. So exercise prescription are as like any other field therapy exercises. The only thing is we add up the scoliosis specific principles from this 7 schools of thoughts. Okay, but that's what basically I do. Okay, because each school has their own positive points and negative points as well. So we take the positive points and we try to uh, have it combined for a particular patient.
okay, sir. And one more question from Dr. S. Ramesh Kumar: what is the severity of scoliosis which can be treated conservatively and with surgical correction? which is the best method of corrective surgery?
Yes. So the best method of corrective surgery I cannot comment, but so the severity of scoliosis which can be treated conservatively. Yes, that's what. So within 45 degrees. Okay. If the curve is less than 45 degrees, or even we can push to 50 degrees. So if the curve is between 40 to 45 degrees curve angle, then it can be managed conservatively. Okay. Surgical correction is what paper says is beyond 45 degrees, then surgery is the only option. Okay, but we can take as I said. Okay, you put up your primary goals, secondary goals. Try to make sure if the curve starts to progress from 45 degree to 50 degree, 55 degree in the 6-month period, then surgery is the only option. But within the 6-month period, if the curve reduces from 45 degree to 40 degree, that says that conservative management has an effect on it, and we can progress on maintaining it. So till a child is completing his 18 to 20 years, or in other words, we say the child is completing um, skeletal maturity, the conservative management can have an effect on it. Okay, so
Okay.
that needs to be followed.
Okay, sir. Thank you. And this will be our last question. This is from Mohammed Taufik. What is the prognosis of tethered cord syndrome with scoliosis?
Yes.
Tethered cord syndrome with
Yes.
scoliosis.
Yeah.
The
So by
prognosis is
that, I
asking.
presume that there might be some neurological involvement also. Okay. So obviously, so when there is a neurological involvement along with scoliosis, then obviously the prognosis is going to get worsened. Okay. So if the underlying neurological involvement is not there much, okay, then it can still be managed, but always monitor on the neurological part as well. Okay. So if there is a neurological involvement, then the prognosis is going to be not good as expected.
Okay. Okay, sir. Thank you for all your answers
I
for
think we
the
are on time
questions.
as well.
Yeah, so it is raised, and so we are on time. So I will, Kiran, we'll just go with a word of thanks.
A lot of thanks,
Shall
sir.
we wind up or?
Yes, sir. Yes, sir. I
Oh,
think there is no more questions, yes, sir.
yeah, there is no more questions. So we are just done with the question answer session, and we will just go with the form
Special
play.
thanks to Dr. Franklin, sir, for introducing Dr. Joseph Samuel, sir. Joseph Samuel, because when we are searching for a person who can manage conservatively for scoliosis, and this Dr. Franklin, sir, who recommended Dr. Joshua, and we are very fortunate enough to have Joshua on this webinar, and he has given much more awareness to even physiotherapists regarding the scoliosis. And now I think we'll be the person who will be identifying a female students for scoliosis, and definitely will improve the quality of life for them also. And I don't know whether we have any data related this to this scoliosis of the government or with any private bodies in the India. Maybe Dr. Joshua would have come across all this data related, and he has given the prevalence also there. And
Yes.
it was fortunate, and it's very a good topic for today's session. And I'm very thankful to Franklin sir and Dr. Joshua also. And sir, on behalf of sir Selvamani sir, can give a vote of
Yeah, I'll just go ahead, and one more thing, they are asking for some feedback link. Whether we are having any feedback link, Dr. Kiran, so
uh,
that we can just get
sir.
the feedback also. That we
Yes, sir.
will,
Yes, sir.
yeah.
I think you
I
can.
think we can just go with their email.
Yes, sir. We can contact the Tamil Nadu IAP official website pages or Dr. Joshua's for a personal WhatsApp number for any queries, and he will answer in detail also if necessary.
Yeah, okay. Uh, All right, so I'll just go with the vote of thanks. Good evening, everyone. I'm honored and lucky to have the opportunity to give a vote of thanks for this wonderful session. Let us be grateful to people who enriches our knowledge. It is really a wonderful brainstorming session where we just simply used to know about the basics of the scoliosis, but here he had just gone through within the time limit. He had just gone through various school of thoughts and the measurements and the management of the scoliosis. So it is really it is a wonderful session, Dr. Joshua. I, Professor
Thank you very much.
Sellumani, EC member, Tamil Nadu IAP, on behalf of Dr. Krishna Kumar, President, and other office bearers of Tamil Nadu IAP, would like to extend my gratitude to Dr. Joshua Samuel Rajkumar for giving us a wonderful session. Thank you, Dr. Joshua. I
Thank you.
would like to extend my thanks to Dr. Sanjeev Jha, President, IAP, Dr. Suresh Babu, Vice President, Dr. Annamalai, General Secretary, and Dr. Ruchi Varshani, Treasurer, for providing us a wonderful platform to Tamil Nadu IAP and to all the physios by streaming this webinar live in YouTube channel IAP India and also in Facebook. I also thank the Central IAP for giving a great opportunity to Tamil Nadu IAP to organize such webinar on the auspicious day for all physiotherapists throughout the world. Last but not the least, I thank wholeheartedly all the participants who participated in this session in large number and enriched their knowledge about various aspects in diagnosis and management of idiopathic scoliosis. I would like to thank you all again for making this session a very meaningful one. Thank you, one and all.
Thank you. Thank you very much.
To the
Yeah,
technical
thank
team
you,
who
sir.
have provided us all the support that we need, and thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, Dr. Joshua. Thank you,
Mm,
Thank you.
everybody.
Bye bye.
Bye, sir. Thank you, sir.